No, go.
I'd just like to introduce Paolo, who's came to us from the US and does a lot of stem cells.
8 years ago.
8 years ago, and he's going to talk about some of the other things we're doing.
Good morning. Can you hear me in the back? Great. So let's see. So my task today is to give you an overview of new treatments at Charing Cross. These are my disclosures. You can see that compared to Dr. Nicholas, I'm really cleaner, but it's not because I'm more virtuous, just because I'm not as much in demand as he is. So I'm going to try and step down because it's really impossible to see the screen from here. I don't know how you did it. So these are the numbers giving you an overview of the group of people who are treated with different disease-modifying treatments at Charing Cross. In my presentation, I will focus in particular on two treatments, Fingolimod and Alemtuzumab. In addition to the newly introduced approved disease-modifying treatment, as alluded previously by Richard, we are part of trials, and as also alluded to from Professor Chandran, we are also one of the centers who participated in an international mesenchymal stem cell trial, for which we collaborate for additional studies with Siddhartha, indeed. Fingolimod is an interesting compound. I find it fascinating that it's been derived from a fungus, a natural fungus, which contains a substance called myriacin, which has been studied by some clever Japanese researchers and found to have strong effects on the immune system. From that, a synthetic molecule has been developed, and the process has resulted in Fingolimod being the first oral treatment for MS that has been approved. This is a summary of the two pivotal trials that resulted in the approval of Fingolimod, the so-called Transforms and the Freedoms trial, in which it was shown that Fingolimod had a superior effect over interferon beta 1A treatment, as well as against the placebo, in reducing the numbers of relapses that patients experience over a certain period of time. In addition, Fingolimod has shown a significantly different effect in the accumulation of disability over placebo. And although the difference is not spectacular, it was statistically significant, showing that perhaps in addition to reducing relapses, Fingolimod actually reduced the progression of disability. So as a result of these trials, the approval process from the health authorities was initiated. There were, of course, side effects, as for any drugs, and these were carefully scrutinized in the trials. A number of different side effects were reported. One that was really lymphopenia, so reduced white blood cell count. That was really depending on the drug's mechanisms of action. So it was classed as a side effect, but really it was sort of what it said on the tin it would do, and it indeed did and does that. But one of the main side effects that was known to occur were cardiac side effects. In particular, Fingolimod can slow or slows in almost all cases the heart rhythm. And in people who have heart problems, this of course can be an issue also because it reduces the conduction within the heart. Some other issues that were noted were eye problems, macular edema, high blood pressure. And all of this information was fed and into a protocol for starting the treatment that we and all centers that prescribe Fingolimod adhere to. So this is a summary of the development. Fingolimod was licensed in the US in 2010. There were another 3 years until NHS approved its use and released the funding in the UK. We at Charing Cross, and this is largely the work of my colleagues, I have to say, were one of the first centers to start Fingolimod administration in the UK. We organized things. There were some administrative issues to overcome during the course of 2013, largely related to the fact that the initial dosing, the initial administration of this drug requires cardiac monitoring, and indeed the first few patients even stayed overnight as an added precaution. I'll skip on this slide. Which were the entry criteria? As per the approval document, the first patient had to fail one approved treatment, interferon beta. Subsequently, more recently, also having failed Copaxone was allowed as one of the prescribing criteria, which, for reason that we failed to understand, wasn't there in the criteria to begin with. We really didn't understand why. And patients who agreed to be treated with Fingolimod needed to have baseline investigations, chest X-ray, blood test. If they were known to have cardiac issue, they had to have a cardiology review. And as a rule, the first 6 hours from the initial administration of Fingolimod had to be spent in hospital with cardiac monitoring and observations as required. How many of our patients were treated with Fingolimod so far? The latest data cut from June had 164 patients. Of these patients, 17 had stopped treatment at some point, 2 of them subsequently restarting. It's a fairly low stopping rate for any drug that we know of. What was the type of patients who started treatment? This is the breakdown. The majority of patients had relapsing remitting multiple sclerosis. We were part of a clinical trial involving PPMS patients. Average age was slightly higher than, on the older side of our average patient population, largely due, I think, that these were patients who had to have and indeed fail one first-line treatment, interferon beta or Copaxone, which obviously takes some time to ascertain failure. Patients were on average 8 years since diagnosis, and their average EDSS, I'm familiar with this, I'm sure you're familiar with this metric, but just to put it in perspective for any of you who aren't, EDSS of 4, which was sort of the average of our patients starting Fingolimod, were sort of near the middle of a scale that goes from 0 to 10, 0 being perfectly healthy neurologically, with 4 being the point at which people begin to lose mobility. Okay, so this was the average EDSS before treatment. Side effects were as expected, and there were no serious adverse events, nor any prolonged stays. However, as we said, a few people stopped over time. 3 were for allergic reaction, 5 had abnormal liver function tests, 2 cases of macular edema, although 1 was not confirmed, 1 with raised blood pressure, 1 shingles reactivation. Now, some patients got worse, or their MS was not effectively kept at bay from the treatment and may perhaps have even reactivated, with 2 patients having highly active relapsing remitting MS. The outcomes, by considering, as Richard has alluded to, people who worsened by having 1 EDSS point up until EDSS 5, which was the majority of patients, or if no such worsening was occurred, that was deemed stability. And of course, a decrease of 1 EDSS point was deemed as improvement. 21 patients got worse at 12% of the population. For 87, it's too early to establish. We rated 56 patients, so 34%, as improved. So, and I need to emphasize that these are data from an audit, and it's a work in progress. The duration of follow-up, so the length of time that people were followed at this particular audit ascertainment was approximately 15 months. So clearly, longer duration of follow-up is needed to know the long-term effect. Now, this just summarizes some of the pre-test and monitoring that is required to prescribe Fingolimod. The process was to do these pre-testing and monitoring was adhered fairly well by our team at Charing Cross. There was only one relatively minor hiccup, I would say, failure for patients to attend to an eye testing, optical coherence tomography. That's what OCT stands for, to check the retinal thickness, the retinal health. This did not work for a number of reasons in a few patients. So this is so far the situation on Fingolimod. We'll move on to, I'll be happy to take questions at the end, but I'll move on to sharing with you the results with Alemtuzumab treatment. Again, this is an audit with the results that are a work in progress and reflect our center experience. Brief introduction on Alemtuzumab. It was previously called Campeth 1H because it came from the city on Cambridge. It recognizes a protein that is expressed by all immune cells and leads to a long-lasting reduction, a very actually strong depletion of immune cells in the blood of patients who receive this treatment. It's prescribed as a cycle over a few days, once repeated after 1 year, and it can be optionally repeated for another year, depending on patient responses and tolerability. This drug was developed over probably 3 decades, I would say, at this point. Initially, it was developed actually for renal transplant rejection at Addenbrooke's Hospital. It was given in a small cohort of initial patients back in the early 90s. And although there was an initial worsening of patients, which we now understand as being related to a cytokine storm. Cytokines are inflammatory proteins that can be released at the first administration of Alemtuzumab and actually give rise to a transient bout of inflammation. So there was initial worsening, but followed by improvement. And the first studies done in a systematic way in cohorts of patients with MS showed efficacy near the end of last century by Alasdair Coles and his colleagues. This is the first, the main phase 2 trial that was published, showing in comparison with interferon beta 1A, the accumulation of disability in the patients the effect on relapse, again, interferon beta 1a, rebif, high dose versus alemtuzumab, all significant differences. This initial study was followed by 2 phase 3 studies, so-called CARE-MS1 and CARE-MS2, that confirmed some of the observations, particularly CARE-MS2 demonstrated a reduction in sustained progression of disability, so getting worse and staying worse compared to rebif, although many of us felt that this difference weren't as spectacular as the previous studies had anticipated. Nevertheless, this data was sufficient for health authorities to establish that this is an effective and, with some caveats, safe drug to be administered in patients with MS with certain characteristics. Which were the safety caveats that apply to alemtuzumab? Apart from infusion reactions that can be largely prevented or attenuated with corticosteroids, and from some herpes reactivation, the main side effect that was observed in up to a third of patients was of so-called secondary autoimmunity. By this we mean that MS is, we believe is an autoimmune disease, and in somebody who has MS, a primary, a first autoimmune disease, if a second autoimmune disease occurs, we call it secondary autoimmunity. These kind of autoimmune conditions that developed after alemtuzumab treatment consisted largely of thyroid disease with antibodies against thyroid, markers of autoimmunity against thyroid becoming positive, which was not a very serious concern, but a more serious concern was the development of antibodies against platelets that led to bleeding disorder, which in one of the trial of the alemtuzumab trial patient was resulted in death. Now, these concerns have been now largely attenuated by proper screening and monitoring procedures, but they remain something to actively watch for. Coming to our Charing Cross-based treated patient cohort, we treated 22 patients. The longest follow-up was, so the patient who received the first alemtuzumab was treated approximately 4 years ago, and the remaining 21 people at some point between then and few months ago. They were all people with relapsing form of MS, mean age 28. You can see younger than the Fingolimod population, although their disease duration was the same or even higher, thus suggesting that these were people who had a quite active course of disease since younger age. 17 of them, so the vast majority, had already received natalizumab, which is a very active drug that is not given normally as a first-line treatment. So this tells you that this was a very active, potentially aggressive type of MS population. On average, 2.2 prior treatments, so actually natalizumab would have been given after first-line treatment in the typical patient within this 22. So this is the treatment scheme. Over 5 days, the first course, over 3 days, the second course after 12 months from the first one. There were no major adverse events. There was one case of shingles. There were no unexpected toxicities or blood test abnormalities. Should be said that these drug results, as a rule, as expected in profound abnormalities of blood cell counts, because again, that's what it should do. That's what it says it does. It depletes heavily white blood cells from the circulation. This was their entry mean EDSS. So you can see 4.8, 1 point higher than the Fingolimod group. As I told you, this patient population was fairly active. The follow-up with the variable duration of follow-up, as I told you, was very similar. It is a slightly lower number, but we can't say really with confidence that they are any better because of the variability. However, the suggestion is that Alemtuzumab has resulted in a stabilization of their EDSS. I think this we can probably suggest. According to the criteria that we employed for this analysis, 17 of the 22, about 77%, was classed as a responder. Now, in the last few minutes of my talk, I'm just going to allude to two new treatments that have been recently approved and are in the process of being phased in for administration to the patients at Charing Cross Hospital. One new oral treatment that has been approved earlier this year is teriflunomide, or Obadger. We do not have any patients as yet on this treatment, as far as I know. The main concern that arises with this treatment is the hair loss as a side effect. It is also not thought to be the most active of the, surely not the most active of the first-line treatment, though it may, of course, be good for a good choice for some patients, as we all differently respond to treatments. A second oral, which perhaps holds more expectations from the MS patients community and patients and clinicians, is BG12, Tecfidera, which has been in use already, for example, in the United States for a period of time. It has a good size of effect in reduction of relapse rates compared to, for example, interferon beta, which is about 30%. It appears to be more active. Still, it's fairly well tolerated, being the main side effects gastrointestinal. And of course, the mode of administration is a lot more convenient than the injectables, as it is a tablet form. So NICE, the National Institute of Clinical Excellence, which oversees drug approval in the UK, has released a positive appraisal document in August of this year. This is a key conclusion of the appraisal, where it states that patients who can be prescribed this drug need to have an active form of MS, so having had relapses during the previous 2 years, but not a very rapidly evolving severe form of MS, not a hyperactive form of MS, so to speak, for which, for example, natalizumab is an approved treatment. And the manufacturer has to provide BG12 with the discount agreed in the patient access scheme. I don't know what that translates into in terms of costs. But at any rate, we are expecting to have the various steps that the NHS requires for actually starting giving patients this drug within 3 months from this release document. So around November 2014, it should be rolled out. What holds the future? Well, the future is already the present, with new drugs having come in and being utilized. But of course, there is a lot of drug development in MS, and there are trials going on. So things will continue to change, and will continue to change positively with more choices and more effective drugs for people with MS. we hope that this will be matched, this opportunity for giving new drugs will be matched by our NHS administrators and other sources of support with the increased staff capacity, increased room capacity, and also to alternative modes of delivering of and administering drugs, such as, for example, home infusion, which can enable access to this drug of a greater number of people. I'd like to thank people who did actually the vast majority of the work in here. Oliver, who collected and provided the audit data. In particular, of course, the MS consultants, Charing Cross, Dr. Nicholas and Dr. Malik, MS nurses, and the research team who support the research and in part also the clinical service at Charing Cross and at the allied hospitals. And I thank you for your attention. I'm happy to take any questions, of course.
Can I ask you the same question that I asked your colleague, if that's okay?
Yes, of course. Yes, I remember it. But yes, feel free to reiterate.
Thank you. In your personal opinion, whether you think that the Alemtuzumab is better or equivalent efficacy as the Fingolimod? What's your personal opinion on it?
Yes, it's an incredibly interesting question, but I must disappoint you. I don't know the answer. It is, I would say that there are two drugs of comparably high efficacy, and it will really depend on individual responses, whether in a particular individual one is better than the other. In the future, perhaps we will have better tools to predict who is going to respond to what through approaches that are called pharmacogenomics, for example, so checking on people's DNA to see whether they're more likely to respond to one drug versus another. We don't have that as yet, but it is work being done.
Are there any current trials going on with regards to comparing the two drugs? I know there are, for instance, with the Natalizumab and the Fingolimod groups, but is there anything?
Yes, I'm not aware that there are such trials. No. Richard confirms my...
At the moment, they're proposing a trial to try and compare the two directly, but we're not quite... we're not at that point yet. The trouble is they have to get funding, and the other thing is that lots of other drugs come out as well, and so when you do these trials, the trouble is it's a question that we want to know the answer to now, but will we want to know the answer to that question in a couple of years' time? That's the trouble. So I know that certainly there are two proposals going through at the moment to specifically answer that question.
Thank you.
There was okay, there's a number of people with their hands, but this lady was here first, actually. This lady in the middle with the green shirt.
I have a question about whether the JC virus has any impact with Campath.
I'm not aware that any cases of PML have been reported. For some reason, although Campath does induce a strong immunosuppression on the white cell counts, so we call immunosuppressive drugs drugs that kill or reduce to a large extent immune cells, and as a result they suppress immune responses. For reasons that are unclear, Campath does abate the number of the immune cells very significantly. Natalizumab does different things, as you know, blocks the entry of these cells into the central nervous system. And interestingly, CAMPAS is not associated with nearly as many infections as one would expect from such drop-ins in immune cell counts. And in particular, it does not seem to associate with viral reactivations such as the JC virus reactivation that results in PML. So it doesn't do that, but why it doesn't do that isn't clear to us.
I have one more question. Out of the drugs that you did talk about, if you have only been on Tysabri previously, what would you recommend? Only because it's kind of like, you know, you said normally people who have been on 2 or more treatments, and for example, say you've only been on Tysabri, would you still recommend Alemtuzumab?
Alemtuzumab?
Yeah. Would you still recommend that?
In principle, yes. If your question is, do you need to have tried everything that exists before trying Alemtuzumab, I would say no, that is not required. I think a lot will depend, you know, I'm one clinician and you could obtain a different answer from another one and both being equally valid. But I think the argument would be that not only which drugs have been tried, but also the form of MS, the level of activity, will come into play for such a treatment decision. So, Richard, would you like to?
I think exactly. I think it would be each drug. Not every drug will work for each person. So I think we wouldn't. It would be what suits the people's MS and how it responds. So you wouldn't need to start these treatments. The difference between what we've done here is that people have started their treatment quite late compared to the studies. So it was licensed on people who had had MS for 2 to 5 very short periods of time, whereas we give it to people who've been on lots of other treatments. It does seem to have been effective in that context, in our limited look at this about it. So I think we wouldn't particularly be saying we should wait and keep trying lots of treatments. It would be the right thing for the right person, and also the risks, pros and cons of it.
Thank you very much.
Hi, a question really to both of you. I forgot to ask Dr. Nicholas, but fortunately it came up in Dr. Muraro's presentation, and it's about more people and more spaces. There have been kind of ongoing pieces of information that have come out about maybe moving the MS Day unit from Charing Cross to St Mary's or other places, and moving Tysabri out into the Thames Valley. And I just wondered if there was any more you could say about either of those.
At the moment, it's not going to move from Charing Cross. So, and there wasn't a home to expand where we were, but there's an issue with the space, and there's a flu, so we can't expand where we are. So, but potentially there's a plan to move within Charing Cross, but not to move from Charing Cross. And the Thames Valley issue is an ongoing issue that we really would like to be able to develop, but unfortunately in Thames Valley, Wexham Park's been taken over by Frimley at the moment. So when that happens, Frimley have just started doing some infusions for a small group of people. We will see. I think it's really trying to get a space that's stable. This has been our main issue. It's not that we can't move things out, but we don't want people away from the clinical follow-up, which is, I know we're a little bit patchy at times, but if you have an issue, you're there and you're able to address that, and that's very important. It's always been our focus, and so that's been our concern. But potentially with Frimley, we might be able to get some movement on that. But I agree, it's been very disturbing, and it changes every week sometimes.
Hello, a question for you, please, about Tesify, BG12, that's the easy one. You had PML question mark. Does that mean you haven't identified any cases of it in the trials, or it is a possibility?
There has been, how many cases?
About
2?
3 or 4 cases. It's very difficult when people have been on lots of treatments. So BG12 was a variant of a drug that was used in, another variant was used in psoriasis, in skin problem in Germany. And there's been some cases, but people have been on lots of other drugs and treatments. So that's why it's a question about it, as I say. But so we just, at the moment, not in the trials, not that we've seen, but it's just a high, obviously for the MS community, it's a high area of concern about it. So the question mark is, you know, don't know.
Thank you.
Any more questions? Gentleman over there. Wait for the microphone, please.
Sorry. I just had a question on Campath, and this may be, you know, it's, I think the trials and the progress has been going on for many years, and I may be very out of date in terms of that, but I thought that and it's about the implementation of Campath. I thought the implementation of Campath, and you were talking about it being an immunosuppressant, I thought the application was pretty much, and this goes back to, I think, when one of these senior golfers was treated with it back at early stages, was to delete the immune system, sort of delete the white blood cell count, and then have it reconstitute itself. But you're talking about immunosuppression, and to me, those would seem to be slightly different things. I mean, one of them is being completely gone,
not,
and you being in a very...
Yes, they're not two different things. So the mechanism of Campath has been proposed and to some extent shown to depend on a depletion, and so a deletion, as you said, of white blood immune cells and a reconstitution with new cells. Now, that hasn't been formally shown, but it is a plausible notion. However, Campath, unlike other forms of this sort of immune rebooting, using other drugs, and what happens, for example, in hematopoietic stem cell transplantation, Campath does result in a protracted lymphopenia, so in a protracted reduction of cell counts, particularly a subtype of T cells that's called CD4 cells. So CD4 cells, this subtype, remain deficient even 2 years after one dose of Campath. And that's why, although I believe that an extent of immune restart happens, it remains a long-standing immunosuppressor. And this may have a role in the side effect that I alluded to, the secondary autoimmunity. Why that exactly occurs, it's not fully known, but the Cambridge group has identified a certain cytokine, a protein that circulates, produced by immune cells, that that is called IL-21, and that for which high levels can predispose to this secondary attack to thyroid or to platelets for reasons that aren't fully elucidated, though.
But you said other than that, you didn't find that you haven't found that there's been a heightened sort of risk of other sort of viral activity or things like
Pardon
that.
Me, I'm missing the...
But sorry, you said before, though, that other than that, you don't see with Campath a heightened sensitivity to viral activity or things like that.
No, high sensitivity to infection, no, has not been seen nor reported.
Yeah. Thank you.
Thank you. And I think they were waving me as time is up. And
yeah, we should
thank you very much for your attention.
Thank you. Yeah.
Thank you.